Nathan, shall I get you to the podium? Is that all right? Thank you very much for coming to this morning session. My name is Ronaldo Bellomo. This is Luigi Camporota from the UK, and we're delighted to have you here. It's a lot nicer here than outside at the moment, so that's good. And we're very lucky to have Nathan Shapiro as the principal investigator of the CLOVER study tell us about what's happening to the Glycocalyx in sepsis. Nathan, the floor is yours.
Sounds great. Thank you so much. So this morning we'll be talking about Glycocalyx and Glycocalyx degradation in sepsis. I'd like to thank the organizers for the opportunity to speak. My disclosures are here, which I don't believe are very relevant to this particular talk, but they're up there. So the first question is just to level set a bit, what's the Glycocalyx? So for those of you who aren't as familiar, it's a gel-like coating on the surface of the endothelium. It's composed of proteoglycans, glycoproteins, and adherent plasma proteins. And it sits on top of the endothelium to regulate things such as vascular permeability, leukocyte adherence, and then also it inhibits molecular thrombosis. So it's really regulating as a partner with the Glycocalyx. So this is a schematic. In the healthy state, we have the endothelium here, and then we have the Glycocalyx, which is this layer on top there, and it's a barrier, especially for entities such as the neutrophil. Now, if we dive down a little bit and look at the components, and the components are important because this is our readout of what's happening to the Glycocalyx. So it's important to understand that when we're talking to you about the Glycocalyx, since it's difficult to visualize the Glycocalyx in humans, we'll spend a second talking about that. What we're doing is we're looking at breakdown components. So it's made of hyaluron, heparin sulfate, chondroitin sulfate, and syndecan-1. So when you see the studies of the Glycocalyx, typically what we're doing is assaying for these types of proteins that might be in the circulation. So this is an EM microscopy. We have the endothelium, and then the Glycocalyx is this kind of hairy layer on top there. So what happens in sepsis? We get Glycocalyx degradation. We get cytokines and other reactive oxygen species will damage the Glycocalyx, or they'll induce shedases. And the shedases, such as MMP, will then start to cleave the glycoprotein. So these fragments are now going into the circulation. We also have heparinase, which cleaves heparin sulfate, also sending fragments of the Glycocalyx into the circulation. There's some different theories out there about other mechanisms. One of the primary theories is that it's ANP mediated, and that ANP release, atrial natriuretic peptide, which is responsive to fluids, will then be released, and that will also induce Glycocalyx degradation, as there also may be some shear stress theories. So now we have our schematic of sepsis. We start to get the Glycocalyx to break down. It allows the neutrophils to have better contact with the endothelium and start to think about transmigration. And then this is the pictorial that we should think about when we're interpreting the studies, that we're having the Glycocalyx breakdown and these components are floating around, and this is what we're measuring as our readout for Glycocalyx degradation. Now, there has been, in the lab, you can do intravital microscopy where you can stain the endothelium, look at vessels, stain the Glycocalyx, and see what's happening. It's not so easy in humans. Some of you may see there's a technique out there using sublingual microscopy where we'll look at the microcirculation, and there's some software that does some indirect calculations about the size of the Glycocalyx. We're still kind of working through the accuracy of that. So again, in sepsis, a couple things happen. One is we have the shedases that are activated, and so this is one way that we're breaking down the Glycocalyx. There's also the theory about excessive volume resuscitation, either initiating ANP to then lead to Glycocalyx degradation, or just directly hitting and damaging the Glycocalyx through changes in tonicity and shear stress. So now let's move into some of the clinical studies that have gotten us to where we are. This is one of the more initial studies back from 2008, and they just compared patients with septic shock to controls. And you see the SYNDICAN-1 level, which is the readout that's being used in this particular study, showing that septic shock patients have higher or more circulating SYNDICAN-1 than controls. And then if we look at SOFA score, there's a direct relationship. So this is supporting the hypothesis that SYNDICAN-1, as a measure of the glycocalyx, is higher in septic shock. This is another trial also reinforcing the same point. Here they're using heparin sulfate as the readout. Again, we're looking for these different fragments floating around. Patients who are septic compared to controls had higher levels, and then non-survivors had higher levels than survivors. So let's talk about just briefly some of the data behind AMP and glycocalyx shed. This is a preclinical trial that was done, and what they did was infuse patients with fluids, and this is pre, this is post, and what we saw was that between pre and post, the ANP goes up and the SYNDICAN-1 levels are going up. These are really not random, like serious randomized clinical studies, but it's kind of trying to build the evidence for this ANP hypothesis. So this is a study that we did that was published a couple years ago in Critical Care, and we're looking at the hypothesis around intravenous fluid being associated with septic endothelial glycocalyx degradation. The functional word here is the association, because this was not a randomized trial. And what this was, it was 56 septic shock patients from the process trial, which was a fluids trial back in sepsis years back, and 15 non-infected controls. We used heparin sulfate as our measurement, and this is via mass spectroscopy. So mass spec for heparin sulfate is probably more accurate quantification of the glycocalyx, or it's thought to be a more accurate quantification, with SYNDICAN lysis being a bit of a less accurate, but also a readout because you're looking at the circulating fragments. What we saw was the same kind of pattern, which is patients with septic shock had higher levels than those who didn't have infection, and then non-survivors in the process trial compared to the survivors. It's going in the direction, but this was clearly an underpowered study with only 8 patients. The other question we asked is SYNDICAN-1 a reasonable surrogate for heparin sulfate via mass spec? So SYNDICAN done by ELISA is actually a lot easier to do. Mass spec heparin sulfate is more expensive, more time consuming, and more technically difficult. And what we see is an okay relationship. So it's definitely representing it going in the right direction. This was not a super large study, so we want to tighten up our understanding of this relationship. But just for perspective, SYNDICAN-1 is a surrogate measure for heparin sulfate by mass spec, which is thought to be a more accurate quantification of the degradation. So at the end of the day, what we saw was an association in this smaller study between heparin sulfate levels and fluid administration, or actually the other way around, fluid administration and change in heparin sulfate levels over time, even after we adjust for SOFA score and age, keeping in mind that a big driver of glycocalyx degradation is in fact sepsis and the severity of it. So we have these two things commingled a bit in the fact that fluids are often just a good surrogate measure for how sick somebody is. Interestingly, in this study, we did not see an association between AMP and heparin sulfate. Again, we're starting to just look for the signal, and we're trying to do this all indirectly by association. So we need more experimental evidence to really decide whether this AMP hypothesis is valid. However, these data kind of just question whether there truly is a relationship between the two. So we pushed this a little bit further, and we did another cohort of patients, and here we took patients who were across a spectrum of severities. So it was going from control patients, we had about 30 to 40 of each. We had non-infected controls, sepsis, severe sepsis, and septic shock. So kind of that spectrum of severity. We used heparin sulfate via mass spec as our primary readout, and we measured patients at enrollment in the emergency department, and then 24 hours later. And here we saw that increase in severity associated with heparin sulfate or with glycocalyx degradation, again, pushing more data in support of the hypothesis that glycocalyx degradation is a player in sepsis and the septic process. It was higher in survivors compared to higher in non-survivors compared to survivors. And when we looked at fluid administration, again, looking at that same relationship, keeping in mind this is all association, we did see that relationship persisted. And what we did was we looked at it when we stratified patients by severity. So this is septic shock patients, this is severe sepsis, and this is sepsis patients, and stratified by severity, that relationship held. If you do a little bit of mathematical interpretation, it's saying that with each liter of fluids administered was associated with 200 nanogram per milliliter increase in circulating heparin sulfate. Again, supporting the hypothesis, but keeping in mind that this is all association. So I'm going to spend the last couple minutes talking about data from the process trial. So from the Clovers trial. So going back in time. So this is from the Clovers trial. The study was called Early Restrictive or Liberal Fluid Management for Sepsis-Induced Hypotension. In brief, this was a trial that compared patients who got a liberal fluid approach, where the strategy overall was to use fluids as the primary resuscitative agent versus a restrictive approach, where the strategy was to use vasopressors as the primary resuscitative agent and to give less fluids. Patients were enrolled early, about 92% from the ED. It was a 24-hour protocol, and the primary outcome was mortality prior to discharge home by day 90. So these are data from the Clovers trial in general, and it just shows you that patients got 2 liters initially and then got more fluids, 2,300 to 500 cc's in the first 6 hours, 3,400 to 1,200, 24 hours, and overall it was about 5.4 liters to 3.3 liters, including pre-enrollment fluid into the first 24 hours. So this is the Clovers trial. Also, patients got vasopressors earlier, more often, and longer. So we have 2 arms randomly assigned as part of Clovers. And there was no difference here in the primary outcome. As part of the study, we also put in a grant and got funded to do a Glycocalyx ancillary study. So here we were asking a couple study questions. Will restrictive versus liberal approach have less glycocalyx degradation? For this presentation, we're going to use Syndican as the primary readout. We're still getting our mass spec data. For the actual study itself, mass spec will be the primary readout as the gold standard, and Syndican kind of the silver standard. We're also asking, are Syndican levels, higher Syndican levels associated with mortality? And is there any evidence of heterogeneous treatment effect by Syndican level? In other words, if we say that we use Syndican as a marker for glycocalyx degradation, one could hypothesize that if you already have glycocalyx degradation, hitting patients with even more fluid is going to be a problem. Whereas perhaps patients with lower Syndican levels who don't have as much glycocalyx degradation, perhaps they could tolerate more fluids. That was our study hypothesis for HTE as to how it might make a difference. So for the sub-study, because all these assays are expensive, we included about 600 patients, and we used an enrichment strategy where we enriched for the outcome of mortality. So we ended up altering the constitution of the population to 270 deaths and 281 survivors. We're going to deal with all the biases statistically. Now, so here's the disclaimer. These are draft results. I got them about 48 hours ago, and I thought it'd be interesting to include in this talk. So the primary manuscript might differ from what you see here, and we're also using the Syndican standard. So for that first question, is there any difference by study arm? I think it's fair to say that there's no difference by study arm. So there's associations with higher fluids, but when we take patients and experimentally test the hypothesis where one group gets more fluids by random assignment to one group getting less, it did not lead to more or less glycocalyx degradation. When we look at survivors versus non-survivors, down below is the distribution for the non-survivors. So clearly there's a shift to the right. These are the box plots. So it's not a perfect predictor, but I think it's pretty fair to say and statistically supported that non-survivors have higher glycocalyx degradation levels based on Syndican than survivors. And when we look overall at the red line is the non-survivors and blue is survivors. The non-survivors come in with higher syndican levels, and those levels stay high, but from day 0 to day 1 to day 3 compared to the survivors. When we look at baseline as an independent predictor and do further adjustment, it sustains as an independent predictor of mortality after adjusting for age, sex, race, severity by SOFA score, and end-stage renal disease. Then we also broke it down by quartile of syndican level. And so this is the lower quartile, second, third, and fourth. And what you see is the non-survivors, they start about the same, maybe a little bit higher, and then proceed to go higher. So if you don't reduce those syndican levels, that was associated with less survival. Same in this quartile. I found the fourth quartile to be particularly interesting, which is they start high, and the non-survivors persist, whereas the survivors will have their syndican levels come down over the next several days. Then when we looked at overall heterogeneity by treatment effect, there's just no difference between the groups broken down by quartile. So I'm just going to move along to end to say, in conclusion, there's no difference between the two groups when randomly assigned. The syndican levels are higher and stay higher in non-survivors versus survivors, and there's no evidence of HTE. So all great hypotheses, but with this larger data set, we're able to drill down a little bit more. And with that, I'd like to conclude and take any questions. With the help, wanted to add that we need to figure out how to restore and protect the glycocalyx. Thank you.
So Nathan, thanks very much. Are there any questions from the audience? Yeah, looks like Jan wants to ask questions. The gentleman there, just 2 questions. Yeah.
When you look at your syndican levels, there's statistically significant differences, but the actual absolute difference is quite small. You wonder, biologically, does that very small difference have a very large effect?
Yeah, no, it's a great question, and it's also the distribution within that very small difference. I think this is exactly where I'm going to lean on my disclaimer and say these are fresh data, and we'll have to drill in a little bit further. But it's a great question, which is what is a clinically significant difference in syndican levels? I think it's a good point. The other thing I will add is those are log levels because we needed to correct for normality. So the actual mean levels, which I didn't show here, there's a bigger difference.
Jan, do you want to ask a question? Or? Yeah. Oh, just shout.
Shout.
Yeah.
Great presentation. Do you think that the effect could be in the very first amount of fluid that you give to these patients? Because also retrospective, when we looked at early vasopressors, where we basically in the vasopressor group gave no fluids at all, there was a huge difference in mortality. So could it be that the first amount is already doing?
Yeah, no, it's a great question, which is one of the things about clovers is that on average patients got 2 liters before entering in the trial due to the logistics of enrolling them and getting them in, et cetera. So it's possible that the damage was done and we're just getting to that baseline too late. It's a great question. One of the things we're going to do in secondary analysis is, remember, it's 2 liters average, so it's a distribution, is look at the patients, because there is a big group of patients who got something like 500 cc's, and we're going to, as an exploratory look, take a look at those patients who weren't exposed to as much fluids and look at their change over time and see what we see. But it's a really good point.
Thank you very much. That's great.
Thank you.
Sorry, I was given the microphone first. Can I add a quick question, please?
Just a short one.
Yes.
Okay. Just wondered, do you know anything about differences in glycocalyx in different vascular beads?
I'm sorry?
Do you know if the glycocalyx differ in different vascular beads?
There's likely to be differences across vascular beds, absolutely. We can just do the readout of the comprehensive readout of what's floating around in the blood.
I'm just going to steal this
Sure.
quick question.
I just couldn't
Sorry.
see you. That's okay.
So, thank you for the very interesting talk. I was just wondering about what kind of data we actually have about the flow rate of the fluids regarding the glycocalyx degradation.
I'm sorry, the flow rate of the fluids being infused?
Yes.
We just have
For
average.
example, whether it differs when you have a higher flow rate and a lower flow rate in terms of the degradation.
Yeah, I haven't seen any such data. We're just going to have readouts over 6 hours and 24 hours, so I don't think we're really going to get to that. But I think it's a great question, which is you slam the glycocalyx quickly, is that more harmful than if you let the fluids drip in? It's a
Because
great
of the shear
hypothesis
stress.
that needs to be explored.
Okay.
Okay, thank you very much, Nathan.
Thank you. And now, thank you. And now it's a pleasure to welcome to the podium Dr. Ince from Rotterdam, who's going to tell us about where do the fluid go. Thank you.
Thank you very much. I lost my voice yesterday, so I hope I will be able to make it to the last slide, so please bear with me. First of all, thank you very much for being here early in the morning. The fluids have arrived outside in Brussels. Now we're going to ask ourselves where the fluids go in the critically ill patient. So I have a declared interest. I have a company that is interested in microcirculation standing outside here. My most important declaration is I'm not a clinical doctor, I'm a physiologist. So I have a bit of a different take maybe on what you do. My interest is trying to find out what's going on, basically. So I think that's important to think when I present some of the thoughts that we have about fluids. And I'd really like to talk about what has happened in the last 10, 15 years regarding the impact of different trials and the role of the European Medical Agency in taking out starches. And I'm a strong believer that if you decide to provide fluids to patients, you should have a broad palette of possibilities for looking at the different mechanisms that you hope to address when you provide fluids. So if we would take the equal scrutiny for saline, I'm sure saline would not pass a phase 1 trial if we would do that. But of course, there's nobody who's going to give the money to do that. So having said that, I'm going to take starches into the equation because basically it's the only colloid that has been studied extensively, and we have learned a lot about how to treat hypovolemia. So having said that, I'm not a great fan of trials because I don't really think that they provide us to the information that you need, which is to know what is going on. When is it going on? Is this what I want to happen? And what is the clinical problem that I'm trying to solve? So having said those things, really physiology is the only polar star that we have. And that's why we first have to start with basics. Is why do you give fluids? What is the clinical problem that you think you are solving by giving intravenous fluids? Well, I guess, again, looking at it from the outside, that you want to treat hypovolemia. But why do you want to treat hypovolemia? Well, the idea, I guess, is that the heart is inadequately filled. It doesn't provide enough cardiac output. That means that there's not enough blood in the microcirculation with blood, which you need to provide the cells with oxygen to sustain organ function. This is, I assume, the reason why for treating hypovolemia, not dehydration, hypovolemia. Well, if that's the case, then oxygen transport is key. So now you're going to give a salty solution with a lot of salt in it, with zero oxygen carrying capacity to treat this clinical problem. And the question is, well, is that a good idea? So if we look at a lot of the papers, you see that there is this vicious cycle, that there's a hypovolemia, fluid resuscitation is given, and then you get all sorts of bad things happening. Fluid accumulation, interstitial edema, all sorts of intra-abdominal compartment syndrome, and then you have to take it out again. And this comes into a vicious cycle, resulting in fluid overload. So let us just take a look at the physiology and the mechanisms of the different fluid types. Do they really improve hypovolemia? Do they stay in the vessels? Well, they don't, at least not crystalloids. They extravagate, extensive evidence for that. Really, within about 30 minutes, it just disappears into the tissues. And if you don't pee that out, then you have all the problems that you're trying to deal with after, and you have to start de-resuscitating. So you see here that if hypovolemia is a clinical problem that you're trying to solve, then colloids are the only logical fluid to give, because as you can see in this figure, and Robert Hahn has done extensive research in that, the colloids, they stay for much longer in the circulation than do crystalloids. So this is an excellent paper by Paul Frost, I think, showing where the different fluids go into the different space. So we've got the intravascular space, we have the interstitial space, also referred to as the third space. And then, of course, we've got the intracellular space. So different types of fluids will distribute among these different compartments depending on their composition. So let us take a look at colloids. So there are a number of microcirculation devices that have been used, and we have used these devices to study what's really going on when you start to give fluids in the patient. Measured sublingually, you can look at the single cells and the distance between them and get a deeper understanding of what's going on. So if we look at crystalloids here on the left, and we compare it to colloids, on the right, the second movie isn't working, but you can see that on the right, the distance between the red blood cells is larger, which is exactly what you would expect from a colloid. So the distance between red blood cells become larger as the colloid takes up the space into intravascular space. And we can, with our technology, we can actually measure the difference between the two. So the crystalloids do nothing with the intravascular compartment. It just disappears into the tissues. But the colloids, they separate the distance between the red blood cells. And that translates itself a lot to the type of clinical experiences which you have, which basically has seen that you need less colloids to reach systemic hemodynamic targets than crystalloids. And if you look at the microcirculation, you see with starches that the distance between the red blood cells and the tissues becomes less. It fills the microcirculation better, resulting in a better ability for the tissues for oxygen extraction because there are more functional capillary densities. So how does this translate to what you see at the bedside? Well, one of the things, of course, is that you see that when you give colloids, you will get, here in the last sentence, a larger reduction in hemoglobin than you would with the crystalloids. So people have said, oh, well, this is the negative effect of colloids. No, it's what colloids should do because they increase the space between the red blood cells, and therefore you start to become less hemoglobin concentration than you would if you just give crystalloids, which just do nothing with the intravascular space. So it's not a bad effect of colloids, it's the purpose of colloids. So what about the interstitial space? Again, as I said before, this third space is just your interstitial space. Fluids do nothing there to improve the physiology in any way. Fluids do not have any business in the third space. And having said that, you're just going to get wet tissues, especially the kidney and the lung, and we know that extravascular lung water certainly is a bad prognosis for the patient. So if we look at actually where all these fluids go, we see that depending on the type of fluids that you have, whether they be, in this case, just albumin or normal saline, that a lot of these accumulate in the interstitial space, which is the thing here. Much less with albumin than with the crystalloids. Okay, so how does that work out? What happens then when you start to intervene because you say, oh dear, we have too much fluids. Now we have to get rid of the fluids. Well, one of the ways to do, maybe, is to provide PEEP. So what happens when you provide PEEP? Well, you start to redistribute the fluids. This is a study we did in Beijing with my fellow Hai Wu Hei, a very nice study on sheep, published in Journal of Applied Physiology, where we directly look at the alveoli on the sheep direct measurement, and we look at the septum. You can see it here. We can just measure quantitatively, and what you basically see is this is not a shock model of any sort. It's just to give cardiac to increase the PEEP, and you see a reduction in the cardiac output, which might be interpreted as the presence of hypovolemia, inviting you to give fluids, and what you basically then see is a septal thickness increases when you give the PEEP after fluid resuscitation, which is pushing actually the fluid compartments into the tissue space, promoting extra lung water. Mechanisms. What is going on? That's what you need to know. What about albumin? Well, albumin is very interesting because it makes use of osmosis. So what happens? Now, this is a study which we did in which we were able to actually measure quantitatively the occurrence of edema. So what we basically do is we measure the focal distance of the microcirculation with the surface, and we validated this in urogynecological patients, and we can exactly say how much edema or tissue space is between these. We applied this technique in burns patients. If you want to really study burn fluids, go to the burns patients. They get liters of the stuff. 25 liters is not unusual. And they have this strange formula called the Parkland formula, in which they first load the patients with crystalloids, and then afterwards in the second phase go on to albumin. And you see very nicely that if you do that and you look at the focal distance, that when you give crystalloids, you see an increase in the third space. All the fluids just go into the tissues. But because burns patients can also have got good kidney function usually, they pee it out again. So it's not that bad as in our septic patients. If you then give albumin, you see that you're very well able to reduce the edema in the patients. So my last couple of slides, I'd like to show you a trial that we did in cardiac surgery patients, asking this precise question: where is the fluid going? We used 3 techniques: non-invasive cardiac output monitoring with the NextFin. We looked at the microcirculation, and then we used bioimpedance to look at the distribution of the fluids in the interstitial space and in the intracellular space. That's the secret space, intracellular space. And this is how bioimpedance works. We used a lot in nephrology, unfortunately not so much in critically ill patients. It's a very interesting technique. And what you see post-operatively is indeed you see an increase in cardiac index, which is exactly what you would expect if you give a lot of fluids. If you look at the microcirculation, however, you see that you've diluted the microcirculation. So increasing the cardiac index has a negative effect on the circulation, is that you dilute the oxygen carrying capacity of the microcirculation by diluting the red blood cell mass. If you then look at the bioimpedance data, you see something very interesting. You see an increase in weight. People get heavier, so they're accumulating, fluids, and you see an increase in the extracellular water, i.e. the third space, which we know already, but interestingly enough, you see a decrease in intracellular water. So you have an extracellular overhydration at the expense of an intracellular dehydration. Crystalloid resuscitation causes intracellular dehydration. And that's not something that I invented. There are many studies done in the 60s, looking at, the 1990s, looking at radioactive with stable isotopes, labeled water, and there they have also found already in septic patients a decrease in the intracellular water. And the interesting thing is that intracellular dehydration causes protein degradation. So here we have an intracellular hit by crystalloid resuscitation. And this is another study done later showing exactly the same thing. Here you see that the amount of extracellular water to intracellular water increases dramatically at the expense of when you use crystalloid resuscitation. And here too, you see extracellular water going up postoperatively at the expense of intracellular dehydration. Last 2 slides are just a comment on the glycocalyx. That too, there are studies, even though Nate did not show that, but there's some evidence that glycocalyx degradation occurs. And my last slide is salt. Why do we never talk about salt? In 1 liter of sodium chloride, there is 9 grams of salt. If you have a patient, and I looked at the slides that Nate showed, liters and liters of the stuff, and you would ask your residents to eat the salt that they're giving to their patients, which is an average of 50 grams of salt. That's a lot of bag of chips, I can tell you that. And this is very interesting studies being done in the nephrology community in which they're asking the question, what does salt do? And this is my last slide. It increases the vascular leakage. What salt does is it accumulates in the glycocalyx and it causes degradation of the endothelial cells, resulting, these were done in healthy volunteers. And the salt that they eat, their high salt is like a pizza a day. It's not that much salt. And Glycocalyx said a couple of weeks ago in a conference in which I was, physiology doesn't need trials, and I would certainly applaud that statement. Thank you very much.
Well, thank you so much for this very interesting talk. I'm just wondering whether there are some questions in the audience. If not, maybe I can start. I mean, you mentioned at the end the importance of, you talked about crystalloids versus colloids, and obviously crystalloids look like they're all the same thing, but clearly you've demonstrated that the type of crystalloid that we use might have a profound effect on your markers. I wonder whether you had some data on the different types of crystalloids with different composition. And the second one was, aside the extravascular lung water or interstitial water that you've mentioned, have you got any other data on oxygen transport, for example, which might be useful in terms of the hemodynamic side?
When giving fluids.
Yes, when giving that.
Although those are two big lectures you're asking me to give.
Very short.
Taking very short the first question that you had, which was the different type of crystalloids. What's the difference about that? So this is my take. It has to start with asking yourself, what's the clinical problem I'm trying to solve? So let's assume that it's hypovolemia. Now, we've got the Ringer's acetate, the Ringer's lactate, and the sodium chloride. I wrote a paper on this in Kidney International, by the way. So the Ringer's acetate seems to be, of the three, the most benign solution. Ringer's lactate has got some negative effects. We've done studies on that. So it causes organ dysfunction, in some cases, especially on the kidney. Sodium chloride, this is my view on sodium chloride. So there's a big thing about hyperchloremic acidosis. And this is what I think is the problem with sodium chloride. You've got a hypovolemic patient which is showing acidosis, metabolic acidosis, and that when you start to give sodium chloride, you're correcting that. But now you change from a metabolic acidosis into chloride acidosis. And if you are not aware of that change, you still think that the patient is still acidotic and inviting you to give more and more of the stuff. So that, I think, is the thing. Acidosis in itself isn't all that bad from a point of view of oxygen transport to tissue. And your second question was regarding the effect on oxygen transport. We've done a lot of experiments on that. And I'm afraid to say that if you have any type of shock, whether it be septic shock or whether it would be hemorrhagic shock, I'm sorry, colloids are the only fluids that you can give. Actually, the only real fluid to give is blood. It's the ideal colloid. It's a viscous solution and it carries oxygen. What more do you want? And it's unfortunate that in sessions on fluids, we don't talk about blood transfusions because that certainly is part of the equation.
Fantastic. Well,
Thank you
very much.
The next speaker is Jan Bakker, who's going to tell us how to assess the degree of capillary leakage. Thank you very much.
Thank you very much. You already heard a lot about the leak of fluids and also the associated measurements. I will give a short summary of can we assess capillary leakage, and at the end show some preliminary results. I have only one disclosure. The study I will present on COVID and sepsis and capillary leak was supported by Daxor company in New York. Now, there are a lot of methods, basically, to measure capillary leak or to measure extravascular lung water, which is, of course, related to capillary leak. Johan Groeneveld, who unfortunately died years ago, did studies when he was in Amsterdam in the VU Medical Center, And a great way to assess capillary leak, but very complicated, because what he used was gallium-67, and he looked at the pulmonary leak index, so he used a probe to put on the lung to detect the escape of the labeled red blood cells. So first he had to take blood and then label it and then put it back into the patient. A very elegant method to study in a, let's say, research setting, the effect of different interventions on the leak of fluids in lungs. But of course, you can imagine that this is not something that you do at the bedside when you're giving fluids. He did great studies, and he showed that the various effect of fluids and the effect of disease on pulmonary leak. More interesting, of course, is the stuff that you can use at the bedside. You already heard about bioimpedance. The PICO device also gives you data on what is extravascular lung water, and with the different equations that they use, remember, you don't actually measure something, you calculate something. They provide you with extravascular lung water and also give you a pulmonary vascular permeability index, and the ratio between pulmonary blood volume and extravascular lung water. So it adds information to you treating the patient at the bedside. Can you do something meaningful with it? Well, yeah, they did. This is a recent study where they looked in COVID ARDS, and they found that COVID ARDS has much higher extravascular lung water than non-COVID-19 ARDS patients. And so measuring this extravascular lung water with a PICO device, and you immediately see the differences, the difficulties in clinical presentation, because the variation is huge in both groups. But at least you can get, let's say, an indication that something is wrong in the lung, and that might, and that will be at the end of my presentation on what to do with these data. Also, if you look at using this at the bedside, Xavier Monet showed that if you use this pulmonary permeability, you can discriminate between hydrostatic pulmonary edema and ARDS, which is, of course, a big difference, because hydrostatic pulmonary edema is a function of the left ventricle, the hydrostatic pressure in the lung. And if you have hydrostatic pressure in the lung, then PEEP could be a meaningful intervention. If you have a leaky endothelium, then probably this should have effect, or let's say a consequence, for the fluids you use and the amount of fluids you use. So this could be a meaningful, let's say, parameter to use when you treat your patients. Now, as I said, there are many methods. The method already introduced by the previous speaker, by John Ince, is impedance. And especially if you use total body impedance, so you attach the probes to the hands and the feet, and so you get not only of the thorax, you can do thorax as well. So you get a complete picture of total body. And different studies have shown that at least it delivers you data that seem to be interesting in treating patients. So this study, one of the very early studies, whole body impedance correlated with total body water volume. Rose from the Netherlands study that changes in resistance related to weight changes. So if you start to accumulate fluid in the body, you can measure it with bioimpedance, and found that it was more reliable than fluid balances. We know that fluid balances in ICU patients are difficult. He found that in some patients, both methods compared well, but in other studies, he showed that actually the bioimpedance is much more accurate. More recently, and this is interesting as well, using lab values. And John Ince already said that changes in hematocrit are related to colloids. But basically, these methods also show that if you have changes in hematocrit, and you don't give blood, of course, because then you screw up the whole relationship, that these changes in hematocrit levels are related to extravascular water in the patient. This is the most recent study by Chandra. Niedermeyer did basically the same, used a different algorithm, but it relies on changes in hematocrit over days. And Chandra used 36 hours and showed that if you use these changes in hematocrit over time, that these correlated with weight and fluid balances. Now, the question is, if you're resuscitating your patient, would you be interested in 36-hour measurements? That doesn't make a lot of sense. It tells you that the patient is doing something bad, but bioimpedance will do the same. And maybe if you have very careful fluid balances, you could get the same information. So the time frame, at least from these studies, is way too long to use in clinical practice for now to decide on do something different if this leak is high. But at least it's a method to track the amount of extravascular lung water. Cordobans in an earlier study used CRP and albumin, and basically it's all the same. You relate lab values, and as long as you don't supply the one of the parameters, so if you don't give blood and you don't give albumin, they track over time, and usually a longer time, the extravascular water. In a very recent study, Walborn did just clinical assessment. And the clinical assessment is complicated because when we see or when your residents or fellows see an edematous patient, they always say, oh yeah, he's hypervolemic. Every round I do in New York is the patient is hydrated because he has edema. But edema is third space. That doesn't mean it's intravascular space. And I will come to that in a minute. This is what Niedermeyer did. So he used plasma volume using hematocrit and a volume for body weight, and came with this study that if you're overhydrated, if you have more extravascular water, then mortality is higher. That doesn't really help you at the bedside, of course. Now, there's another way. It's available in clinical practice. It was developed for cardiology to assess total blood volume and see if patients with cardiac failure were really hypervolemic. Was developed in the 70s. And it's labeling albumin with 125 or 131 iodine. First introduced in 46, but later on developed to use in clinical practice. And basically what you do, you bolus the radio-labeled albumin, and over a period of 30 minutes, I use in ICU 30 minutes, the cardiologists use 1 hour, because these are outpatients. They come to the hospital to, let's say, measure their total blood volume. And then you measure different samples, and the decay in the radioactive sample is a measure of losing your albumin to the extravascular space because it's no longer in your blood sample. That's basically the simple, let's say, characterization. What we did very early in the COVID pandemic that hit New York in April 20, no treatment. We were just treating blood gases and maintaining blood pressure, basically. And we saw all these patients with these huge amounts of edema. And so we studied in a convenient sample at different days COVID patient and measured this transudation of this radio-labeled albumin. And so the patients, one patient was sampled at day 2, day 7, 11, 13, 14, and 20. So these are all different patients. And so we were interested in, is there an, let's say, increasing capillary leak in these patients that causes them to become so edematous. Four of these patients died. As you remember, the mortality in the very early phase was huge, not only related to the disease and the absence of treatment, but we went in, I think, 4 weeks from our usual 17 beds of ICU to 160 ICU beds. So there was a small capacity problem as well. What we found is if you look at the days in the ICU, individual patients on a day in the ICU, and you look at the total blood volume deficit, if you calculate the total blood volume with this method, you can also calculate the, let's say, total blood volume that you would expect if the patient would not be sick, and that's based on the sex of the patient, male and female, and the height and the weight, so the body surface area. And so then you can calculate the deficiency or the presence of fluids. That's on this x-axis, and on the other one is the leak. And what we indeed found is that early in the phase there was a little bit of leak, and the later phase COVID patient had a very high leak. And this was associated with overhydration in the beginning and hypovolemia at the end. So basically the message was, if you have a high leak, despite the fact that you have edema, you have intravascular low volume. So you're basically hypovolemic in an edematous state. This is only the albumin transudation rate, and this is the albumin transudation rate and total blood volume. So you see that leak can cause hypovolemia, even though you have edema. Now, the next study that we did, and this was in the late phase, this was last year COVID patients, so a very different mortality in these patients, a very different treatment. A lot of these patients were vaccinated, so a completely different cohort of COVID. And we compared them with sepsis patients. And this is sepsis admitted to the ICU. Now, there's a huge difference between a sepsis patient in an American ICU and a sepsis patient in an ICU in, for instance, the Netherlands. And so this is very low-grade sepsis, to be honest. Only a few had a little bit of norepinephrine. As you can see, the mortality was very low, only 11% mortality. You never get into an ICU in the Netherlands if you have an 11% mortality chance. They treat it on the floor. And so this is a very mixed group of sepsis patients, much less sick than COVID, Apache-wise and SOFA-wise. The age is more or less the same, and the mortality is much lower. Now, what we found is, to be honest, to my surprise, because I expected in these less sepsis patients, if this COVID thing and this infection thing translates to endothelial damage, that these COVID patients, given the first study that we did, would be much more leaky. But to the contrast, we found that we measured at day 1, 3, and 7, and of course you quickly lose these non-very sick sepsis patients over time because they get discharged from the ICU. So we measured till day 7. And you can see that at day 1 and day 2, the leak rate in the sepsis was much higher than in COVID. So in conclusion, there are several methods that exist to measure capillary leak: invasive, non-invasive. The leakage of radio-labeled albumin has probably fewer confounders, because if you give blood or if you give albumin, it doesn't screw up your calculation. Of course, it's limited that you cannot do multiple injections over a day to measure the effect of a liter of fluids. But it has less confounders. In the ongoing study of recent COVID and sepsis, We didn't see the similar effects. Sepsis had much more leak. And of course, at the end of the day, the question is, what should I do? Conceptually, if you have a leaky endothelium, I completely agree with John Ince. You should not give crystalloids, but try to give a colloid in a New York University hospital. It's impossible. You won't get it. You have to rely on albumin, and then you start getting phone calls. Try to give a blood transfusion to a sepsis patient, you get even more phone calls. So it's impossible not to give crystalloids because nothing else is available. But that should be, at the end of the day, the ultimate consequence if you find these leaks. Now, the company will come with a bedside measurement, and so it will be much more clinically applicable. But at the end of the day, the question still remains, am I able to change my fluid infusion practice given these data? Thank you very much.
Thank you very much, Jan. Got time for one quick question, if there is anything from the audience. If there isn't one, I'll just ask one quickly.
Well, to be honest, I'm totally not interested in cardiac output at all. The question is, when the circulation is adequate, who cares? That's absolutely true. Why would you give fluids, or why would you resuscitate the patient if the circulation is okay? That's why we did the Andromeda. If capillary refill time is an adequate marker of an okay circulation, then please do nothing. And if you get anxious about the blood pressure, give some norepinephrine.
Sounds good. Thank you very much.
Thank you very much. Now it's my pleasure to welcome to the podium Sascha David from
Morning. There should be a question mark, I guess, but the title I was sent has no question mark. So we will see if there are new therapeutic options or not. So the topics are picked, so potentially we need some time. Sure, you've heard about this, and then also some glycocalyx balancing enzymes. I thought the first talk from Nate was about this. Couldn't be here, unfortunately. In our body, you know that this would weigh about 1 kilogram, has a huge heterogeneity. If I look at the endothelium in my brain or in my kidneys, it looks really different. It's all covered with the glycocalyx. In just a few phenotypes that you directly can adjust to a clinical picture that you know. So it's the intravascular coagulopathy that's driven by an endothelial dysfunction together with this pro-adhesive situation. So if I have an infection of an upper right lobe, I want my endothelium to recruit leukocytes. So they express adhesion molecules, and that's a good thing. The infection. If this happens everywhere in my body, you have massive inflammation, you have a trigger for organ dysfunction. So it's all started with endothelial dysfunction. Obviously, hemodynamics, nitric oxide synthase, vasodilation also comes from the endothelium. The microcirculation, and last but not least, the topic of this talk, the increased permeability. And many, many mediators have been identified that play a role here. From the physiological textbook, we know that we have this transcellular and the important for us. So these junctions that you probably still know from med school, the tight junctions and the adherent junctions, they can disassemble, and then the endothelium gets leaky. And these junctions are anchored with each other, and they have a connection to the cytoskeleton, which is the actin. So if the cell contracts, this also transduces forces to these junctions. And many pathways have been identified that are involved in the regulation of this, and I pick now a few of them, of which I think a treatment at least could be available in the future, or some not so far future. So this angiopoietin type 2 system is my bias. simple, to be honest. So it's a tyrosine kinase receptor similar to VEGF that we all know. It's expressed on the surface of an endothelial cell, and the difference to many other systems as a protective effector, so it's anti-inflammatory, anti-apoptotic, and anti-permeability. If I have an infection, I remember the right lobe, pneumonia or whatever, antagonist of this receptor, that's termed angiopoietin 2. So if I want to be leaky at a local position, my endothelium can release Ang2, it blocks this, and then it expresses adhesion molecules, and it gets leaky. And this is old data, that's why we still have severe sepsis here, but you can see with increasing strata of the disease, you will find an increasing amount of this angiopoietin 2 in your blood, because all the endothelial cells are just releasing it as an inadequate reaction. And this nicely correlates with the severity of illness, and it even discriminates of a cohort here. I think of 100 patients or so. So the question at that time, and this is actually when I met Nate in Boston, was, is this a real mediator or is just a biomarker that is an epiphenomenon? And to test this, a very simple thing would be to make a mouse that lacks this dies almost by 100% within, let's say, 2 days or so. And a mouse that is similarly septic, with a ruptured appendicitis model, has a much better So then we tried, if this is really a mediator, it makes sense to modulate this system to have a treatment, a potential treatment. And that's just one approach how this has been done, because targets angiopoietin 2. And then you make a mouse septic, and I'm very thankful for the previous speaker who spoke about albumin as a marker of permeability. And this is labeled albumin in blue, and you can see that the septic mouse lung is completely blue because all the albumin that's covalently bound to a blue dye has leaked into the vasculature. If you perform the same experiment with a mouse that has been treated with this molecule that targets angiopoietin 2, you block this development of leakiness, and the mouse has a stable vasculature. Just one example, and this also translates into improved survival. So if you think about this conception, to either use strategies that would strongly activate the receptor. This has been done. This is a small compound that has been produced in Canada that binds the receptor and turns it on, cannot get off anymore. Or in oncology, where this receptor is also important for angiogenesis, so tumor neoangiogenesis, nowadays we have antibodies, monoclonal antibodies, that target angiopoietin 2. So it would be an easy way, to test this in a context of capillary leakage. And I will come to this with another method how we can modulate this in a minute. So a second target I'd like to highlight would be the adrenomyelin, because it's a little bit more developed. This is a bioactive protein, very small protein, 52 amino acids, and it has two major functions. You can see here the blue dot, that's the adrenomyelin intravascular, where it promotes mostly an anti-permeability effect acting on these junctions. But it can also travel to the extravascular space, and there it has a totally different function. On the smooth muscle cell, it leads to relaxation of this cell. So this would mean it leads to vasodilatation. So it's not a good thing to have your adrenomedulin in your extravascular space, because it would lead to hypotension, but it would be a good thing to have it in your vessel, where it would promote anti-permeability effects. And this is also served as a biomarker. You can nowadays use it as a point of care method to measure the amount of adrenaline in your blood. The higher the level, the more likely to die, more or less. So why is this interesting in terms of a target. And I struggled a bit that I first heard about it, what the concept would be, but it's a really clever concept, I think. So the whole idea would be to keep your adrenomedulin all in the intravascular space, to keep your adrenomedulin active and in your intravascular space. And they did this in a clever way by designing an antibody. We always think of antibodies as something that is function blocking. That's not the case. That's an antibody that binds adrenomedulin. So we have now this blue dot that's really big. It cannot travel anymore through the junctions and do bad stuff to the vascular smooth muscle cell. It stays all in the vasculature, but the blue dot is still active. So biologically, this adrenomedulin still prevents leak, but it cannot go anymore in the interstitium where it would cause hypotension. So it's a cool, clever truck, I think. And the same is true for this trial that they then did, a safety study, phase 2 double-blind study, where they also used a stratification tool by only including patients that really had increased adrenomedulin. And they included sick patients with septic shock, and they performed a single infusion with 2 different doses. Primary outcome was safety and tolerability, but they also had a few secondary outcome points that they investigated. So it's a busy slide, but if you just compare red with blue, red is placebo, blue are different treatment doses, you can easily see that there doesn't seem to be a signal in terms of adverse events. So this giving this drug in different doses, 2 patients in a randomized setting seem to be safe. And if you look at some of their secondary outcomes, this is a graph showing the SOFA score. You can see that in the adrenomedulin, atrikizumab-treated group, the line is below the other one, but it's not significant, at least not except for the very first day, where it looks like in the control group, the SOFA score went up by 1 point, whereas in the treatment group, it went down by -0.5. I think we should not overinterpret these findings. The study was not designed to show efficacy. That's a pure safety study, but we have to wait for the follow-up study. And this could be an interesting tool available for us at the bedside. It was also used in COVID as kind of therapeutic interventions in single cases. And here again, if you look at mortality, at least the lines are in the correct direction as you want them. So the atrikizumab line performed better, but it's not significant, so you cannot say better per se. So, and the third target I want to highlight would be a target of the glycocalyx, and this has for sure been introduced in more detail than I will do it to you, but just brief repetition here. A very complex structure of a network of transmembrane proteins, mostly heparan sulfates, that are involved in a ton of processes. One is permeability, but it's also involved in signaling. It's a co-receptor for many other proteins. So we need an intact glycocalyx on our endothelium, that's pretty sure. And we know that during systemic inflammation, this is somehow degraded dramatically. And it's mostly done by enzymes that chop their specific targets into small pieces. And I picked here heparan sulfate because this is the most abundant structure in the glycocalyx as one example. So the heparan sulfate can be chopped into small pieces by an enzyme that's called heparinase 1. And during sepsis, the heparinase 1 gets upregulated. But interestingly, our body has a counterpart. It's a little bit like this angiopoietin 1, angiopoietin 2 story. A good guy that turns it on, a bad guy that turns it off. Here we have an enzyme that chops this, but we also have an enzyme that protects this cleavage. And what we know from the septic patients is that they have very high number of heparinase 1 or activity, and they have an acquired deficiency of heparinase 2 activity. So the question for me would be, how could we rebalance this system? And there's another bias of myself because I'm trying to run a multi-center trial on this technology in sepsis, and one of the arguments why I believe this could be goes along these lines. So it's an extracorporeal treatment that separates the cellular components of the blood from the plasma. The plasma is discharged, it's all in the trash, and fresh plasma is used to resuspend the cellular components, and it goes back into the patient. And you combine thereby 2 different things with one procedure. You get rid of a ton of probably injurious molecules, I'm not even so sure. I believe much more important, you replace protective factors that are just consumed by this disease process. So you're not just taking something out like a cytokine, you're just bringing stuff back that's consumed. And I would show you the example of the heparinases to make this point. So one intervention, 2 global mechanisms, but multiple targets that can be tackled with this treatment. And we are now looking at the heparinases. And this is These are healthy controls, essentially ICU stuff from our ward, where you can see that the heparinase 2:1 ratio is in favor for 2, so they have protective enzyme. Their glycocalyx is in sharp, and in septic shock, this dramatically goes down. If you now perform a plasma exchange in such a patient, you completely rebalance the system to a normal homeostasis kind of thing. And I have unfortunately picked a little bit of a wrong figure here. I'm sorry for that, but I still can make the point. This was now a controlled setting. So, and this is angiopoietin 2. Remember I said it's exocytosed everywhere in the body, so it's really high, 10 nanograms here in the middle. And these are septic shock patients that have been treated with standard of care, volume resuscitation, antibiotics, everything we do on a daily basis according to guidelines or your preferences. And these are patients who additionally were treated with one single plasma exchange. And you can see that obviously you also take out this permeability-inducing factor from the intravascular compartment. This is the wrong graph. I wanted to show you the Ince correspondent to this, which goes up because it's in healthy plasma. Essentially what you do is a regression to the mean of a healthy society. And does this matter? Does this close the leak? One, I think, last cellular image looks a little bit goofy, but it's important that the bedside, I think, cells adjacent to each other, and here in green are these adherence junctions. That's what holds the cells together. If I put a little bit of blood on these cells, they contract, so the cytoskeleton contracts, and the junction disassemble, and you see that these gaps develop between the cells. And this is the cellular correlate of your patient in severe capillary leakage syndrome. You perform a plasma exchange, you rebalance your heparinases, your angiopoietins, adrenomedulin, you name it, and you take a drop of blood afterwards and you stimulate your cells, you completely avoid this phenotype. And this can be quantified. That's really subjective, so I can take a nice picture and show the picture. It's more to make the point, but you can quantify this with machines that measure the resistance. So if you put blood from these 20 patients on the machine, you can see that immediately the resistance drops, the cells contract, and the holes are there. And if you do it with the same 20 patients, just 2 hours later, nothing happens anymore because the homeostasis is rebalanced in the system. And is there an effect of this? Yeah, I see the clock, I'm almost done. Yes, it increases hemodynamic stability. You can see that norepinephrine goes significantly down, and it also reduces, and this was really very much to my surprise, stroke volume variance. So the preload is much better, although you need less volume. So to sum this up, closing, sorry. It looks like if the time is over, they just skip you out. I cannot go back, but I think I tried to convince you that 3 potential targets are of interest. One could be this angiopoietin type 2 system, one the adrenomedulin, and the glycocalyx, using very different structures and approaches. And with this, I'd like to thank you for your attention.
Well, thank you so much for this wonderful presentation. I think we've got time for only one quick question, if there is one from the floor, if possible. I can't see any hands up, but...
Okay, thank you very much.
Thank you.
That's great. Moving to the next speaker. Craig Coopersmith is going to tell us about gut permeability. Thank you very much.
Thank you, and thank you so much to the organizers for having me here. Like my timer's going off, but I have no slides. So there we go. So I was given this title, Gut Permeability is Altered, So What? So it literally has nothing to do with the other 4 talks today, except for a couple of my slides will look just like the previous person's about how permeability is mediated. My disclosures are here. None of them are relevant in the slightest to the talk that I am giving right now. So again, different from what everybody else has talked about, gut permeability. So there is a single layered, 1-cell gut epithelium that separates our bodies from the 40 trillion microbes that live within us. The epithelial monolayer has to prevent unregulated paracellular flux of pathogenic luminal contents, while also allowing selective paracellular permeability that's required for nutrients and water absorption. And this balance is dysregulated in a critical illness with intestinal hyperpermeability. As we just heard from the previous speaker, paracellular permeability is controlled by apical tight junctions, well, he's got a cooler picture than I have, which are functionally and structurally linked to perijunctional actin myosin ring, and inflammatory mediators totally change that in critical illness. So, can we measure gut permeability at the bedside? It turns out we can. This study came out a year ago. Use of a sensitive multi-sugar test for measuring segmented intestinal permeability in critically ill mechanical ventilatory patients. Small study, only about 30 patients or so, but all mechanically ventilated, all fed, looking at different sugars. I'm not going to spend any time on this other than to say that you can, in a basic way, measure whole gut permeability, and you can measure small intestinal permeability, although strangely, they were not successful in actually measuring gastroduodenal permeability. But this is something that we could do on some level at the bedside. But I was given the title, so what? So the original concept of gut permeability in MODS, which I learned in medical school, I imagine a lot of you did. But look at this. This came out in 1986. Critical illness induces intestinal hyperpermeability. Intact bacteria leave the gut lumen, entering previously sterile environments, and that cause systemic illness. Makes sense. But if it's correct, how come all of our patients don't have E. coli bacteremia? They don't, right? And it was actually kind of proven wrong about 30 years ago, in part, in a trauma study in which something that I cannot believe they got through the IRB, portal venous catheters were implanted for sequential blood sampling at 6, 12, 24, 48, and 120 hours after major torso trauma. And they found bacteria detectable in the portal or systemic circulation in 2% of them. In 8 patients, and 7 of them were contaminated, so was staph epi. And so that would start to indicate that, well, maybe we don't have what we learned about in medical school. We don't have bacterial translocation to everybody, and so why do we care? So if it's routinely increased, yet very few of our patients are actually bacteremic, does hyperpermeability actually matter? And so the one take home I want you to get from today is gut permeability is more complicated than most people think. Most people think that there's a single bacterial translocation and they measure it through one thing, which is FD4. And it turns out that's not correct. So how is gut permeability mediated? There's actually 3 different pathways. The first is the POR pathway, and this doesn't come from critical illness. This comes from friends of ours who work in inflammatory bowel disease. A lot of this was mediated by one of my collaborators, Jerry Turner at Harvard. The POR pathway is high capacity, size and charge selective route. Only tiny molecules, less than 8 angstroms in diameter, can go through the POR pathway, which is mediated by the entire Claudin family of tight junctions. Then there's the leak pathway, which is low capacity, non-selective route, which has larger molecules, still not bacteria, but larger things such as LPS can vastly the leak pathway, less than 100 angstrom. That's the thing mediated by things like occludin, ZO, GEM-A, and also the mediators of the ring that our previous speaker spoke about. And finally, we have the unrestricted pathway, which is actually tight junction independent. Well, you learn all about tight junctions, and the unrestricted pathway has nothing to do with tight junctions. That has no size limit. That occurs where there's epithelial damage, like apoptosis. And that's actually the only place that bacteria can cross. So while everybody thinks bacterial translocation, it turns out it's totally independent of the tight junctions, because what the tight junctions mediate is smaller molecules. So put another way, the gut barrier prevents molecules of different sizes from leaving the gut lumen. These range from tiny molecules to macromolecules like endotoxin to all the way up to intact bacteria, each controlled by different pathways. And even if bacteria are not translocating, bacterial products, other things within the gut lumen, can in fact have distant effects. And in fact, we know that the gut has distant effects. I'm obviously not going to go over this slide, but this is a nice paper that came out in Critical Care last year showing distant effects of the gut-brain axis, the gut-liver axis, the gut-everything axis. And it's important to say that all 3 pathways are dysregulated after sepsis, at least in mice. So this is published from our lab. The next couple are not going to be. This is the leak permeability. So again, when most people look at leak, they look at FD4. I'm sorry, when they look at permeability, they think FD4, that's what they're talking about for permeability. And that, in fact, is increased as early as 1 hour and stays up for at least a couple of days, again, in mice using a appendicitis model. I'd ask you just to look at the top of this and the next one. This is all unpublished. It's under peer review right now. This is looking at pore permeability in sepsis. The tiny one, that's markedly up too. and so is the unrestricted pathway. So all three pathways are actually worsened in sepsis, even though bacteria can only go through one of them. So what happens if we target this? Again, this first set of studies is under peer review right now. We're going to be resubmitting it in a couple of days. This is looking at the Claudin family. So this is looking at Claudin 2. So we're going to start with human tissue. So to the best of our knowledge, this is actually the largest human study ever of gut in the intestine. By taking about 100 patients, is 101 patients, 44 who were septic from intestinal perforation, and 57 who had intestinal resections from other reasons not having to do with sepsis, not looking where the perforation was, looking distal from the perforation. So we're not looking to see what happens when your intestine has a hole in it, but your sepsis from an intestinal hole and downstream, you actually can look at the intestine. And this is looking at Claudin 2. And so Claudin 2 is our pore-forming pathway. What we see is a marked upregulation of Claudin 2 in the human intestine in septic patients. So many of our speakers have spoken before about the concept of association versus actual, mechanism. So what do we do then? We then went to a mouse model. We look at a mouse model. We first see the exact same thing in mouse. Then we see an upregulation of Claudin 2 after sepsis in the mouse. Again, it's just a nice association. What should happen when we knock out Claudin 2? Pore permeability should become normalized. And in fact, that's what we see over here. So the wild type animals are at the top, the knockout animals are at the bottom, and what we see is a normalization of permeability specifically through the pore pathway after permeability, after sepsis. Again, not large enough for bacteria to get through, not large enough for LPS to get through, but we can normalize pore permeability. And when we do that, what happens? It actually normalizes systemic inflammation and it improves survival, having nothing to do with bacterial translocation. What happens if we go to larger now? Now we go to targeting the perijunctional ring. So this is MLCK, myosin ligase kinase. MLC phosphorylation is mediated by MLCK, which is critical to the regulation of the intestinal barrier function, just like the endothelial barrier function, as it results in contraction of the actin-myosin ring, which in turn increases permeability. A lot of words. Simplistically, if you knock it out, you should prevent hyperpermeability. I've already shown you this. This is what happens when we make a mouse septic. Permeability goes up through the leak pathway. This is now FD4. This is what happens to the leak pathway in MLCK knockout mice. Literally nothing. By normalizing MLCK, we prevent hyperpermeability through this different pathway than I previously shown you, and we can normalize permeability through this pathway, which in turn prevents systemic hypercytokinemia, not a change in bacteremia, a change in cytokines, because again, bacteria aren't large enough to get through this, but you can have a change in inflammation, which in turn, at least in animals, leads to 100% survival. It can get complicated. So I talked about molecules, the previous speaker talked about molecules. They're in both places. They're in the endothelium and they're in the gut. This is looking at JAM-A. So JAM-A is markedly increased in sepsis. And when we knock out JAM-A, we see an increase in FD4. So we see an increase in leak permeability. That should be bad, right? More stuff leaks out, and that should be bad. And in fact, more stuff leaks out, and blood cultures get better, and cytokines get better, and mortality gets better. I'm not going to get into why this is because, I have 15 minutes and each one of these could be a long talk. But the bottom line is gut permeability is never in isolation. The things that affect permeability, number one, affect permeability in other cell types, but number two are often put on different other cell types having nothing to do with permeability, which is actually why the JAM-A, even though there's a worsening in permeability, you ultimately end up with an improvement in mortality. Finally, moving to our third pathway, we ask the question, is permeability dependent upon apoptosis? Remember, the unrestricted pathway, which is the one that bacteria go through, is the one that is dependent upon epithelial damage. So what happens if we change epithelial damage, if we change apoptosis? Does that change permeability? A long time ago, like 20 years ago or something, we showed that preventing gut apoptosis improves survival. We didn't look at permeability because we were looking at apoptosis at the time. This is just showing that gut apoptosis is increased. It's increased in mice, in pneumonia, and it's increased in patients. An autopsy study that we did with my very, very old mentor, he's not old, but a mentor from a long time ago, Richard Hotchkiss, showing that there's increase in gut apoptosis in patients. And if we prevent gut apoptosis by overexpressing BCL2, we actually can normalize gut permeability. Switching gears to what's inside the gut lumen, right? So what's inside the gut lumen is our microbiome. This is a slide from Paul Wishmeyer. It was never actually published because they made him change this in the actual journal, even though this is better than the actual figure they published. This is us versus our patients. We're red, our patients are blue. Our microbiomes look totally different. And gut microbiomes are associated with 28-day mortality in critically ill patients. Again, those two studies and a million others are associative, and the fact that there's a change in the microbiome, it doesn't tell you whether it's good, bad, or indifferent. And so this is a study that we did to ask if we can if we can identify the role of the microbiome in critical illness in a preclinical model. So what we did is we took genetically identical mice from different vendors. Identical. They have the exact same genes, but we buy them from different vendors, so they're going to have different microbiomes. Same age, same sex, same genes. Only difference is their microbiome. And you have a totally different survival. The one with the more complex microbiome has a much better survival and actually a more robust immune function, which I'm not going to show. They have differences in the alpha and beta diversity. And so again, differences in survival is associated with different microbiomes. How do we determine whether this is causative or not? We take advantage of the fact that mice are not people. If you co-house mice, they will eat each other's stool. Only female mice. If you co-house male mice, they'll fight to the death. If you co-house female mice, they're happy, they're friends. But because they're mice, they eat each other's stool, and so they develop a common microbiome. So they start with different microbiomes, you put them in the same cage together, they end up with the same microbiome. When you put them in the same cage together, even though they start with different microbiomes, they end up with the same microbiome. Complicated slide, I know I have a minute left, but I only have a couple of slides left. The left and the right are the microbiomes from the two different vendors. I hope that you can see that the one all the way on the left is more complicated than the one all the way on the right. There's more colors, more bars. When we put them together 3 weeks later and we assess their microbiome, we have the two in the middle. They look nearly identical, and they look identical to the one on the left. So they both develop the more complex microbiome. The one that started with the complex microbiome keeps it. The one that started with a simpler microbiome, simply by eating stool from an animal with a more complex one, develops a more complex one. And now we make them septic, and what we find out is, by changing the microbiome, there's no intervention, simply by changing the microbiome, all of a sudden mortality gets better, proving causally that changing the microbiome is actually changing mortality, which again gets down to is the microbiome and the microbiome products. And then taking this out, this came out like on Tuesday night, and I had to change my talk because this came out on Tuesday night in Nature Medicine, and this is back in patients again. Dysbiosis of microbiota immune metasystem in critical illness is associated with nosocomial infections, which is a very long title, but ultimately showing that there truly is a metasystem that goes back and forth between the immune system and the microbiome, which obviously is changed by gut permeability. And this is just one teaser of a slide from this incredibly complex paper that shows that in patients, not animals, that in patients with enriched Enterobacter in their guts, they have a totally different chance of survival and of getting a nosocomial infection. But it turns out that it's not as simple. You might think, okay, Enterobacter is enriched. They're going to get infections with Enterobacter. And if you look on the right, they're way more susceptible to nosocomial infections. But it's not nosocomial infections with what they're enriched with. They're not nosocomial infections with Enterobacter. They're nosocomial infections of everything else. And so there's this complex interplay between the microbiome changing in permeability and ultimately susceptibility to the immune system. And so that gut permeability is actually way more complicated than previously understood. And all three pathways of gut permeability are increased in sepsis via distinct tight junction dependent and independent mechanisms. Targeting gut permeability is actually a potential therapeutic target in sepsis. And there's multiple preclinical studies and now actually some clinical studies demonstrating the differences in the microbiome are mechanistically responsible for changes in survival, and emerging human studies showing the same thing. Thank you guys very much.
There's just time for one quick question, if anybody has a quick question. Should we do stool transplantation, Greg?
Talking about that at like 2:30 this afternoon.
Okay, very good then.
You'll have to wait in here.
Listen. Okay, thank you.